Good afternoon, friends. It's our honor and privilege on behalf of Sankara Academy of Vision to welcome Professor Gordon-Shaag who's the chairperson of the Department of Optometry at the Hadassah College. It's our honor and privilege on behalf of Sankara Academy of Vision to welcome Professor Gordon-Shaag who's the chairperson of the Department of Optometry. So apologies for that. So once again, it's my honor and privilege to welcome Professor Gordon-Shaag, who's the chairperson at the Department of Optometry at the Hadassah College in Jerusalem. Professor Gordon-Shaag has her current research interests in epidemiology and etiology of ocular disease and refractive error. And today, as a part of our commemoration of the World Sight Day, she's going to interact with us and give us insights on the clinical advice to families of keratoconus patients. Over to you, Professor.
Good afternoon, everybody. I would like to thank the Sankara Eye Foundation for this wonderful idea. I think it's a great way of improving vision. And I would also like to thank my good friend Aditya Goyal for inviting me to give this talk. So today I'm going to talk about clinical advice to families of keratoconus patients. I'll go through this quickly because I'm sure we all know that keratoconus is a corneal disorder. It's progressive. The cornea, which is typically shaped like a dome, takes on a conical shape. Early people are asymptomatic, but as the disease progresses, so does vision. It causes irregular astigmatism, myopia, corneal scarring, and a certain percentage of patients with keratoconus wind up having cornea transplants. Keratoconus is very prevalent in Israel. Our research has showed that in Israel, the prevalence is 2 to 3%. And I looked for what the prevalence is in India, and I found that there's a similar prevalence of keratoconus in India. In the Maharashtra region in central India, they found that it was 2 to 0.3% based on steep keratometry. And maybe you could write in the comment section in YouTube if you think that reflects what you see in your clinical practice, because I'd be really interested. We see lots and lots and lots of patients with keratoconus in Israel. So the research that I'm going to talk to you about today is research that we did at our college on the prevalence of corneal abnormalities in first-degree relatives of patients with keratoconus. It's done with my colleague, Dr. Einat Schneer. And if you take out your QR code readers, you can get a link to the paper, which is available via open access. So as part of our research into the etiology of keratoconus, we ask our patients if they have any first-degree relatives with keratoconus. So you can see in 5 studies that we did over the years, we found that in 4 of them, something like 25% of the patients with keratoconus reported having a first-degree relative with keratoconus. When we ask the control subjects, only like 2 or 3% of them reported having a first-degree relative with keratoconus. And it raised the notion that keratoconus is very, very prevalent within the first-degree relatives. I'm going to show you a pedigree of a family, and which also really is one of the things that instigated our research. We had a student in the Department of Optometry who was 24 at the time, and she had a severe case of keratoconus. She was already post corneal transplants in both eyes. And we asked her if any of her family members had keratoconus, and she said, no, no one has keratoconus. And so we suggested she bring them in for a full eye exam. And it turned out her mother had keratoconus, and one of her brothers was a keratoconus suspect. And the mother had poor vision, had scissors reflex. She had been to the ophthalmologist and optometrist, and no one had diagnosed her keratoconus. And this really raised the notion and made us think that it must be true that there's a lot of corneal abnormalities in family members with keratoconus. So we did a research project in which we recommended to all our keratoconus patients to bring in their first-degree relatives. First-degree relatives are parents, children, siblings, for a full exam. And we did an exam using corneal tomography. Corneal tomography gives us a three-dimensional image of the front and the back of the cornea, and in fact, the entire anterior chamber. We also performed a full eye exam, including visual acuity, slit lamp, retinoscopy, to look for the typical signs of keratoconus. So we managed to recruit 15 patients into this study. I'm sorry, 16 patients into this study. Most of them were men, only 38% were female. You could see the average age, and I'll just point out to you, things that we typically look at. They had very steep corneas in the anterior cornea, the posterior cornea, and very thin corneas. So the first thing we did is we recruited their first-degree family members, and we got 56 of their first-degree relatives to come in and do exams. And the first thing we looked at was the corneal topography patterns. And so I'm just going to remind you of some of the typical corneal topography patterns. I'm not showing, these are kind of schematic diagrams of some of topography patterns. We have round patterns, oval patterns. This is inferior steepening, and this is superior steepening. And all of these patterns were defined as normal corneal topography patterns. And we have abnormal corneal topography patterns. I'm showing two of them. One is inferior steepening, and the other one is inferior steepening with an asymmetric bow tie. And you can see the bow tie here is skewed. These are typically patterns that we see in keratoconus patients, and these patterns are not necessarily seen in keratoconus patients. So we compared the prevalence of abnormal topography and normal topography between the blue, which is the healthy control, and the orange, which is the first-degree relatives. And what we can see is that there's a much higher prevalence of abnormal corneal topography patterns in the first-degree relatives of patients with keratoconus. And it's statistically significant. So the normal controls were more likely to have a normal corneal topography pattern, and the first-degree family members were more likely to have an abnormal corneal topography pattern. So the consensus on keratoconus is that corneal tomography is the most sensitive tool for detecting abnormalities. So we looked at corneal tomography. Now again, corneal tomography is giving us kind of a three-dimensional look into the cornea. We can see the thickness, an entire thickness map. We can look at the posterior curvature. We could look at elevation, both anterior and posterior elevation. And the parameters that we looked at in this study were central corneal thickness and thinnest corneal thickness. In a normal patient, the thinnest corneal thickness and the central corneal thickness are typically in the same place, the apex of the cornea. But with keratoconus patients, typically the thinnest place is the apex of the cone. The instrument that we use, the Sirius CSO, has 6 other parameters that I want to describe. One is symmetry index in the front and the back. It's based on corneal curvature measurements, and it's a measure of how symmetrical the cornea is. Now, in normal patients, it's going to be pretty symmetrical, and in keratoconus patients, it's going to be pretty asymmetrical. There are another 4 parameters that are based on corneal elevation. And we're also going to describe these parameters. So the first thing we found when we looked at the 56 relatives is that 2 actually had keratoconus and didn't know it. And I'm sorry, there's a typo here, but 8 were diagnosed as keratoconus suspect, and that's 14%. So between the keratoconus and the keratoconus suspects, 18% were either keratoconus or keratoconus suspects. And we didn't have any in the healthy controls. So what I'm going to show you in the next slide is a quantitative analysis of these parameters that we discussed here. So here we see prevalence, and here we see the different parameters. And what we're showing in orange is the family members of the keratoconus patients, and in blue is the healthy controls. And the star indicates parameters that were statistically different in terms of prevalence between the first-degree family members and the healthy controls. And you could see the thinnest corneal thickness, the symmetry indices, and all the elevation indices defects were much more prevalent in the keratoconus first-degree family members than in the healthy controls. If we take them all together, 34% of the first-degree relatives had at least one defect. Well, only 14% of the controls had at least one defect, and this is statistically significant. So what we see here is that if you take first-degree relatives of patients with keratoconus, they're very likely to have something funny going on in their cornea. Either the cornea is too thin, the cornea is asymmetrical, the cornea has elevation defects, and at least a third of them. And it's not just that they had one defect, the keratoconus relatives had many defects. In this table, we see controls and first-degree relatives. Here's the number of eyes. Here are the number of normal corneas. Okay, in the controls, 86% were normal, and in the first-degree relatives, only 66% were normal. And if we look at the number of defects, the keratoconus relatives had lots and lots of defects. 4% had 3 defects, and 11% had 4 or more abnormalities. And we don't see any of that in the controls. When we look at the relatives, both men and women had an equal amount of abnormalities. And we see a positive correlation with age, meaning the older the relatives, the more likely they are to have abnormalities in one of the corneal parameters. And it was true for every corneal parameter that we measured. So based on this, we have the following clinical recommendations. First of all, it's important to state that we have a way of helping people with keratoconus that we didn't in the past, and that's corneal collagen cross-linking. Corneal collagen cross-linking stops the progression of the disease in patients with keratoconus. It doesn't necessarily make the vision get better, but it'll stop the vision from deteriorating. So we want to be able to identify people at the earliest possible stage, follow the progression of their disease, and if it progresses, offer them collagen cross-linking. If we can accomplish that, then we can, first of all, maybe they'll be able to get by with glasses and not need specialty contact lenses. And certainly some of them will be saved from having a corneal transplant. So really, I think our goal as clinicians is to identify people with keratoconus as early as possible and refer them to corneal specialists to see if they're a candidate for cross-linking. And so since we see such a high prevalence of corneal defects and keratoconus in the first-degree relatives, we have the following clinical recommendations. If you have a patient with keratoconus, you should recommend that they bring in all their first-degree relatives for vision exams. And it depends what you have in your clinic. Certainly we all have retinoscopes. A retinoscope is an excellent tool for looking for patients that have scissoring reflect. I don't know about in India, but in our research in Israel, half of patients with keratoconus don't know that they have keratoconus. I can't tell you how many patients come in and tell us, oh, we've been told by the doctor that we have a lazy eye. And we check out that lazy eye, and that is not amblyopia. It's a patient who has a unilateral keratoconus, and we're able to fit them with contact lenses, and they no longer have a lazy eye. And I believe that if practitioners use the retinoscope to look for the scissors reflex, there would be a lot of patients with keratoconus who get diagnosed. If you have a slit lamp is an excellent tool for looking for corneal thinning. Keratometry to look for steep K or astigmatism. And of course, if you have a tomographer or a topographer, to look for abnormal corneal topography patterns. And if you have a tomographer, which is really the best way of identifying early keratoconus, to look for abnormalities in any of the parameters. So the younger family members are more at risk. So, you know, if we have a patient with keratoconus who's in a young adult, we ask them, do you have any younger siblings? And we ask the younger siblings to come in. If we have patients with keratoconus who are a bit older and have children, we try to bring in the children as soon as they can cooperate with, you know, retinoscopy they can cooperate with usually, but as soon as they could cooperate with tomography and topography, we try to do tomography and topography. And we believe that if we do this, we'll be able to identify children who are at risk for having progressive keratoconus and get them in the care of someone who can do corneal, collagen cross-linking before their disease becomes severe. So those are our clinical recommendations. Again, I want to thank the Sankara Eye Foundation for this fantastic day. And I see there's something in the chat.
So Professor Gordon-Shaag, there's a question from Liad Gans asking, is there a minimal age for collagen cross-linking?
I'll answer that in a minute, but I'd also like to thank again Aditya Goyal for inviting me, the Oculus Consortium, which really introduced me to the wonderful optometry community in India. And if you want to reach me, please reach me at my email address, and you can use your QR code scanner to scan this that leads to my homepage. So Dr. Gans asked, is there a minimal age for cross-linking? In Israel, I don't do cross-linking, but physicians perform cross-linking on children as young as 8 or 9. It's not so much the minimal age that determines whether or not a person is a candidate for cross-linking. It's how quickly their corneas are progressing. And the younger the patient is, the more we recommend that they do, that we follow them up on a regular basis, because we see the younger children progressing really, really quickly. So a teenager or a young adult or a child with keratoconus, we want to bring them in every 3 months to make sure that there's no progression. And if there is progression, then we're going to consider doing cross-linking. And, you know, and I really would like to invite anyone who has a question. We have an expression in Hebrew that means that, you know, people who are embarrassed to ask questions don't learn. We're a culture that really encourages asking questions. So please feel free to ask questions.
You mentioned about use of topographers to pick up keratoconus early, and you also mentioned about the scissoring reflex. So has there been any study that you've done to correlate both of these? Because almost every child will definitely get a retinoscopy done.
So
is
scissoring,
that kind of an indicator?
Scissoring reflex is an excellent tool for identifying people who already have keratoconus. If you see a child or a young adult with scissoring reflex, it's one of the first things that you need to think about and to send them for to a cornea specialist. the people with keratoconus suspect or the earliest stages will not necessarily have the scissoring reflex. So really, the best tool is to look at their cornea thickness with a slit lamp. And if you have a tomographer or a topographer, use that. And again, if you have patients with keratoconus and you don't have a topographer, I would recommend the children going to a cornea specialist at least once a year, more if possible, and getting topography and or tomography, because that's really the most sensitive tool.
So we do not see any more questions on the stream as of now. So I think they still need to probably interact with you a couple of more times to become a little more open to ask these questions. But what we would invite those who are watching this stream, not just on the World Sight Day, but even subsequently, is if you have any questions that Professor Gordon has been kind enough to share her contact details, so you could feel free to contact her directly, or you post your questions on the chat and we will try and get it across to Professor Gordon and get them responded back.
I'd also like to add that from what I've seen in the literature, there hasn't been a study about the prevalence of keratoconus in India using corneal topography or tomography. And if anyone wants to collaborate, we could really help getting that kind of study off the ground. I think it's really an important study to do.
So there you have it. You've got an invitation on World Sight Day to collaborate with one of the leading universities in Israel, with a person extremely passionate about corneal conditions, about keratoconus, looking at the genetics, looking at the epidemiology. So once again, Professor Gordon-Shaag, on behalf of Sankara Academy of Vision, we do thank you for taking time off and joining us on this live stream session as we celebrate World Sight Day. 2020 has been a year of uncertainty, but I think with us collaborating, we definitely can make sure that people see this world much better. So thank you again, Professor.
Thank you very much. Bye-bye.